Okay, so our first group of presenters, you'll see their names on the slide here. We'll be presenting in this order. So Yael, you'll be first, and beginning at 9:30, Sean, you'll start off the second session. So it's my pleasure to introduce Dr. Yael Feinberg, who will be presenting on faculty perceptions of refugee and immigrant health in undergraduate medical education. So Yael, over to you.
I'll start off by just apologizing that I messed up on the date. I was reviewing this last night and I caught that I didn't change the date. I'm on mat leave now with my third, so needless to say, it's a busy household here. And if one of my big girls discovers me hidden outside and runs out, apologize in advance. This was my FMRSP project, which I did, as you can see, present last at mini Rio back in the fall. But just to recap and kind of get myself back into it and to get more of a running start on the project. So next slide. So a bit about the background and why we chose this topic. So a fifth of Canadians are foreign born. Every year there's 300,000 refugees that come to Canada, which 300,000 newcomers to Canada, which 10% are refugee. I guess it'd be interesting to see how things are going to be different for 2020 with our borders closed, but I'm sure we're going to see in the years to come probably some repercussions from the events related to the current pandemic. The newcomers to Canada have a lot of unique healthcare needs, so related to mental health, infectious diseases that we don't see as often here in Canada, some genetic conditions, and then there's all the language and cultural barriers, just to name a few. We're also aware of the healthy immigrant effect that when, based on self-reported data, when people come to Canada, they rate their health better than the average Canadians, and then this declines over time, the reasons of which are numerous and quite interesting, but definitely is an area for us to intervene. Next slide, please. So the main question was, currently there's no uniformly mandated undergraduate medical curriculum for refugee and immigrant health education across medical schools in Canada. So we started this off by looking at what do faculty at the different universities perceive as the current state of refugee and immigrant health education at undergraduate medical schools across Canada. Next slide. So how we did this. So this went on last year, so December to May last year. So first we identified faculty leads using the AFMC Global Health Contact List and also through word of mouth. So we identified faculty leads across the 17 medical schools. And then there was both a qualitative and a quantitative aspect to the study. I just got all the points, thanks. So for the qualitative, we set up interviews over Zoom. So this was my first introduction to Zoom over 1.5 years ago. Little did I know how Zoom would be so much part of my life now, but we did the interviews over Zoom, we recorded them, and then we transcribed them using Otter, and then going over them manually as well, just to ensure accuracy. We had 2 reviewers, and we analyzed the themes, quoted the topics, and then analyzed them to get emerging themes using qualitative analysis. And then we also had a follow-up survey using SurveyMonkey. This was our quantitative piece to it. And that was analyzed with Excel. And then just to note, we did 13 of the 17 med schools with the interviews, and then we were able to cover 14 with the follow-up surveys. And then this was deemed QI, so we didn't need full REB, which was good. So just for the sake of this short presentation, just this diagram kind of summarizes the themes that we had from our qualitative analysis of the Zoom interviews. So 6 main themes. So first, what was the actual educational content presented? The way that the curriculum was developed, small group, large group, community service learning for some examples. Other topics that came up were the way that refugee health was integrated into the broader curriculum, the way that refugee health overlapped with other vulnerable populations, challenges of making curriculum changes, and also the importance of sharing information between universities. Yeah, so like one quote, talking about the community service learning, which is where a medical student kind of volunteers with a refugee family, and how it's a way, opportunity for them to liaise with the medical community over on as a positive interaction. Next slide. And then integrating it to the broader curriculum. So instead of like having a definite lecture on refugee health, that here's another factor, and here's a cardiology case and an MSK case. So you have in the cardiology section, the patient is a refugee as well, and integrating that into their curriculum that way. So yeah, lots of commonalities between the different programs, but still a lot of variation. A big emphasis on how community service learning can help foster the cultural competencies, and then just some limitations. The faculty that we interviewed didn't necessarily represent their institutions, and then also that we had a lot of difficulty getting in contact with the Quebec universities, and they weren't so well represented. And then in terms of future directions, we also did a student survey, and then we hope to kind of compare the faculty and the student perceptions as well. And eventually to develop a panel of experts to develop a curriculum framework through a Delphi process that can hopefully be implemented across the universities.
Super.
Yeah.
So next up, we have Dr. Satele Chesky.
All right, bonjour everyone. Can you hear me?
Yes.
Great. So bonjour, and thank you for logging into this short co-video series on refugee primary care. So I'm Satele Chesky. I'm a family medicine resident at Montfort, and I have a special interest in obstetrics. So that's the expose I will be bringing you today with this maternal health care access. Next, please. So while in Canada, luckily, we already have a little bit of an introduction about refugee health from Yael, so I can skip through a bit of this. But basically, Canada does have quite an excellent track record compared to a lot of other westernized nations in terms of accepting a lot of refugees in recent years. However, these refugees tend to face a lot of challenges with their health upon their arrival. And pregnant women in particular are very vulnerable population with a lot of known differences in healthcare outcomes. In particular, pregnant women experience higher weight of low birth weight babies. They tend to receive more C-sections and have higher rates of postpartum depression. So knowing this, I wanted to focus my research on whether a lack of access could be a contributing factor to these inequalities, and because access is something that could hopefully be addressed. Next, please. So in order to do this, we conducted a retrospective case control study of low-risk pregnancies at Montfort Hospital. And we basically looked at a primary outcome of whether or not first contact was made with an OB provider within the first 12 weeks of the pregnancy or after, and compared refugee to non-refugee women. We chose 12 weeks as a cutoff because in the first trimester, first 12 weeks, there's a lot of opportunity for risk assessment, for counseling on lifestyle, diet, and other issues, and also for offering screening. And so it's hopefully a time where we could intervene if there was better access. Next slide, please. So just a very quick run through here. We ended up with a total of 50 pregnancies, 25 in each group, which was not quite as many as we were hoping, but we actually still had some significant findings, so that was great. And the groups were similar in number of pregnancies per woman and also in age. Next slide, please. So we found, in terms of our primary outcome, that refugee women indeed were more likely to present later for obstetrics care, with a significant value there. 24% presented by 12 weeks versus 72% in the non-refugee group, which is quite interesting. Our study, unfortunately, wasn't able to, in the short duration of time that we had during residency, to determine reasons for this, but literature suggests that there could be kind of some physician reasons in terms of physicians being a little bit reluctant to take on refugee patients due to logistical challenges, which I think hopefully is a little bit in the past. now with some amendments to the refugee health coverage, but it could also be on individual level. Research suggests perhaps that this could be because of perceptions about pregnancy that vary between cultures, or perhaps because of poverty, education issues. And it also could be because of a systemic level challenges that these women face in, knowing where to access the system, for example. In terms of secondary outcomes, we had some other interesting findings. So despite the fact that refugee women tended to present later for care in their pregnancy, interestingly, what you can see in the table here is that they actually ended up attending a similar number of visits throughout, which is surprising. And we didn't explore why this is, but it could be perhaps because they have more complicated pregnancies, or obviously also because there's probably some other variables that we did not account for. Other things, so we had an overall low folic acid uptake in both groups, but refugee women tended to be lower than non-refugee women, and although non-significant, it was approaching significance, and perhaps with a larger sample size, this would actually be a finding that would be interesting. And interestingly, and the final finding I would like to highlight is that we found, sorry, just the previous slide for one more second, just that rates of postpartum depression screen were actually significantly different between the two groups. And although they were low overall, they were slightly higher in the refugee population, which is actually quite encouraging. Next slide, please. So although it was an interesting study, we were limited by our small sample size, and we were able to have a significant finding regardless, but for secondary outcomes, we were not always powered enough to have the findings, or to have information on whether findings would be significant. And basically, in conclusion, what I want to leave you with is that despite these limitations, hopefully the study will help you to remember some of the pearls that you can each contribute to refugee primary care. We can all do our part by helping these women to access care, by reaching out, promoting early folic acid uptake in all women, and also by taking the time to screen for postpartum depression, because that's really important, and it's starting to be recognized as more of an important issue. So this way we can each help these women have the safest pregnancies they can. So thanks very much for tuning in. Take care.
Thank you, Stell. Terrific. And now, Dr. Trevor ONeal, you're up next.
Great, thank you. Good morning, everyone. Thank you for having me. I'm a resident at Primrose Family Health Team, and I'm excited to be here to present my FMRSP. So if we go to the next slide, please. So it's well known 24 to 40% of emergency department visits are deemed inappropriate and could be better managed in primary care. Next slide. So at my practice site, Primrose Family Health Team, we have a much lower rate of patients attending the emergency department for non-urgent issues compared to the region and the province. So potential contributing factors may include same-day appointments, evening and weekend appointments, nurse-led phone triage during office hours, and resident-led call during after hours. Next slide. The purpose of my FMRSP was to assess the impact of nurse office hour triage and resident after hour call on preventing Primrose patients from using the emergency department for non-urgent issues. Next slide. So to do this, in collaboration with the nurses, we designed an EMR stamp for them to use during their triage encounters to assess the impact of preventing patients from using the emergency department. And we also analyzed resident after-hour emergency call EMR notes to assess their impact on preventing non-urgent emergency department use. The setting was Primrose Family Health Team, and our population was all Primrose Family Health Team patients directed to nurse triage or who used the after-hour call service during the period of October 4th to 17th, 2019. The next slide. So table 1 and 2 here present patient demographics for nurse triage and resident call respectively. If you could just hit next again, please. So I'd just like to highlight here that for nurse triage, which in table 1, most assessments were for patients age 0 to 9 years of age, as well as 50 to 59 years of age. And similarly, in table 2, for resident call, most of the after-hour calls were for patients 0 to 9 years of age. Next slide. So through table 3 and 4 here represent the outcomes of nurse triage and resident call respectively. So again, if you could click next. Thank you. And table 3 shows that nurses believed about 33% of triaged patients would have attended the emergency department for their issue if triage was not available to them. And then with triage, all of these patients were diverted to clinic and given same-day appointments instead. And for table 4, residents believed approximately 29% of after-hour calls would have attended the emergency department if the after-hour service was not available to them. And of these, they believe they were able to divert approximately 75% of patients from going to the emergency department with reassurance and education, or by giving them a next day appointment in clinic. The next slide. So our findings suggest that Primrose nurse triage and resident-led after-hour call do contribute to emergency department avoidance for non-urgent issues. And nurses believe they were able to avert all the patients that they thought of otherwise would have attended the emergency department without triage available to the patient. And residents believe they were able to avert 75% of patients they thought would have otherwise attended the emergency department if after-hour call was not available to them. And these findings are consistent with prior research. Next slide. So I just wanted to touch base on our new COVID reality. So many of us are currently using phone encounters to assess urgency for patients to be seen. In my experience, patients are currently staying away from the emergency department, and triage may help to avoid unnecessary visits and also ensure appropriate emergency department use when necessary. And new phone billing codes make on-call service financially viable for physicians, and this should be further studied as we move towards more virtual care and algorithmic triage. Next slide. So on limitations, so we had a small sample size. We were limited to one geographic location at my clinic at Primrose. We think that in the winter season, during viral season, it may be even more effective to have triage and after-hour call available to patients. Number of nurse triage assessments was lower, and we had recent nurse model changes and increased workload, which may contribute to that. And of course, we can't associate causality with any of this because the nurses and residents subjectively indicated whether they thought the patients would have gone to the emerge, and we were not able to actually confirm the ultimate decision that the patients made. So just next slide. Just want to thank Dr. Johnston, all the Primrose Family Health Team nurses and residents who helped me with this study, and Roland for helping me extract the data. Thank you.
Okay, Andre, you're up next. Dr. Andre.
All right. Hi, my name is Andre. I'm one of the R2s from the Lamont stream, and I have this actually ties very well into Trevor's project. So my project essentially was a review of the referrals sent to the Lamont Hospital Emergency Department in 2016-2017 for hypertension. Next slide, please. So as you all probably know, hypertension is one of the most ubiquitous diseases among Canadian adults, and it's not surprising that there are a lot of emergency department visits for hypertension. And now, when I tried to look at Canadian data to see how many of them are appropriate referrals to the ED or appropriate presentations to the ED, unfortunately, it was relatively lacking. So that's kind of where my project aimed to address these questions. When you look at American data, the overall amount of visits for hypertension that are true hypertensive emergencies, meaning target end organ damage that needs aggressive antihypertensive treatment, so they need an ED, they need an ICU, they need transport to tertiary care, etc., is very, very low. About 2 in every 1,000 of those hypertensive visits end up really requiring those aggressive care. And in Canada, our practice guidelines differ widely between hypertensive emergencies that need that aggressive care and a hypertensive urgency that just that's a uncontrolled blood pressure, but is better cared for in an outpatient setting with a short but appropriate follow-up. Slide, please. So this is my project in a nutshell. I'm sorry that you lost the bottom there, but so I essentially did a cross-sectional chart study review during the 2016 fiscal year, just give or take. So out of the 54,000 people, more or less, that show up to the MOFOR every year in their ED, about 254 of them ended up having a diagnosis of hypertension. And so when I looked at those 254 people and looked at which one of them were sent by another healthcare practitioner, being it a family doc, specialist, sometimes even pharmacists, nursing homes, etc. And about 1/4 of them were sent in there. So 67 of them. And out of those 67, 0 had met criteria for hypertensive emergency. The remaining 3/4, or 187, were self-referred or walk-in patients that came in of their own accord. And out of those, 6 patients ended up meeting criteria for hypertensive emergencies. They needed admission, ICU, transferred to another institution, or they died. Next slide, please. So in 3 minutes, I couldn't go through all my tables, so I just kind of shoved the four most impressive stats that I found during my study. The first one being that a significant percentage of the patients that I looked at didn't require any investigations at all when they were in ED. Almost over a fifth of the self-referred patients came in, had high blood pressure, but weren't investigated for anything. A very small percentage of the patients in ED actually even got antihypertensive medication. Almost a third of the referred patients didn't get anything during their stay. They just were in emerge. And less than half of the referred patients were even sent home with an outpatient prescription. So overall, didn't get much treatment while being in emerge. And a large percentage of them, especially the referred patients, for 37.3%, had no symptoms coming into the emerge other than their uncontrolled high blood pressure. Next slide, please. So overall, I think my study showed two main things. The first one being that, as we could have assumed with the American data, hypertensive emergencies are incredibly rare. With my data, which is a very small sample size, it ends up being about 1 in 9,000. But the sample size is too small for that to be really of any significance. And importantly, none of the referred patients required any type of aggressive care. And if you add up during that 1 year size, that's over 1,100 years of patient time just sitting in an ED. And when you think that less than half of these people even got any kind of treatment whatsoever, that's a lot of time you're spending in the ED just to be sent home for no discernible benefit for those patients. So I think a lot of them could have very much benefited from outpatient treatment. There's a lot of limitations to my study, which I can't really go through in 3 minutes, but I think one of the most important ones is that just because these people didn't always have hypertensive emergencies doesn't mean that they don't deserve to go to the ED, especially since I can't comment on how these patients look like, how they presented to their primary care physicians. For instance, 4 of the patients had chest pains, 2 had vertigo, and 2 had paresthesias, which in my mind is a very appropriate reason to send someone to the ED if they're suffering from retrosternal chest pain. I'm hoping that this data can be helped to better inform guidelines into who should be sent to the emerge and who shouldn't, especially considering our COVID era, where our emerge is a precious resource and we want to avoid sending people there as much as possible. Thank you guys so much. I hope that was 3 minutes.
So my FMRSP was studying the question of how much family medicine residents sleep. You can go on, move ahead. The first question is really who cares? After all, traditionally residency has been a period of grueling, long hours and sleep deprivation. Well, importantly, sleep can be seen as a surrogate marker for wellness. When wellness is poor, sleep is often the first thing to go. Acute sleep loss has been shown to result in decreased mood, cognitive performance, and motor skills, amongst many other deficits. But the effects of sleep loss are also chronic, cumulative, and dose-dependent, with chronically poor sleep resulting in decreased executive functioning, memory, reaction time, emotional regulation, burnout, many other things. Many of these deficits are especially important to residents who are tasked with making important and difficult medical decisions for patients. And in fact, multiple studies have shown an association between poor sleep and medical errors. Poor sleep among residents is well documented and unfortunately is associated with negative mental health outcomes, including a more chronic course of depression amongst depressed residents. When residents are surveyed, they associate poor sleep with lack of motivation to learn, as well as an impairment in knowledge acquisition, something to be aware of on a educational and departmental level. Next slide. So I asked residents to voluntarily complete a survey of their sleep habits, initially for 7 and then to increase uptake for 3 to 7 days while on their family med rotation. I used the consensus sleep diary, which is a standardized expert opinion sleep diary, somewhat adopted for the purposes of this investigation. And I decided to exclude in-hospital call, which I wasn't sure would add to the question of how much residents sleep well in unit. After all, we already know that most people get poor sleep when they're on in-hospital call. The study variables were time in bed with the intention of sleeping, number of nighttime awakenings, total time of nighttime awakenings, and subjective quality of sleep. For the nights where residents noted that their sleep was poor, I also asked them if they believed it contributed to the quality of their care the following day. Next slide. So there were only 9 residents surveyed. The results are summarized here. Amongst all of them, average time in bed was 7.8 hours. Average time of sleep was 7.4 hours. About a quarter of nights were felt to be poor quality, and about half of those nights were felt to negatively impact patient care the next day. Averages are somewhat limited in utility because of the large disparity. So like you can see, participant 5 actually got on average 8.8 hours a night, which I think is unthinkable. But participant 4 got 5.6 hours a night. So there's a large disparity there. Next slide. So needless to say, this survey is highly limited in its utility, mainly due to the very small sample size, which I tried to get past, and a number of other biases, but it does still leave some food for thought. Although there's a large disparity amongst the participants, sleep time was actually similar on the whole to the general Canadian population, and significantly better than previous surveys of other residency programs that I was able to find. There are some interesting things to note. One is the disparity between time spent asleep and time spent in bed, which is a measurement known as sleep efficacy. Potential causes of poor sleep efficacy for residents may be community call, waking up all night with calls, or being anxious, like lying in bed with racing thoughts. Another important note is that around half of the poor quality nights were felt to negatively affect clinical care the next day. This should not be surprising because it's consistent with the data that sleep deprivation causes decreased alertness, medical errors, lack of empathy, etc. But it should be concerning. Since we also know from previous data that people tend to be unaware of the deficits they experience from sleep deprivation, I would postulate that actually much more care is negatively affected. Next slide. So a few take-home points. Residents often get mixed messages about wellness, and the explicit, and I guess medical students as well, the explicit messaging we receive often conflicts with the hidden curriculum. I don't know if it's really possible to maintain true work-life balance with the number of obligations on us as residents, and I think that sleep is often the first thing to go. Between clinical requirements, studying, and call, residents are taught to prioritize our wellness by socializing, exercising, spending time with family, preparing healthy meals, etc., etc., etc. So how much time is there left to sleep? Another note is that we spend over half of our time in residency on off-service rotations. Although I didn't study this period, it's important to be aware that sleep debt is cumulative, and the poor sleep we obtain off-service likely affects us even while on service. This could be a potential area for future study. Next slide. So thank you all for listening, and thanks to Dr. Mercer for his supervision.
Maybe I'll just talk as it's going. But anyway, so what I'm doing is I'm giving an update of my project that I've been working on. So Doug, you can just keep it playing, and I'll just try to say everything as it's going.
Okay.
So what I've done is I've made some tools for our EMR, particularly for preventive care. So I'm showing it at the top here. It's showing off the, most clinics have a toolbar at the top that collects some of the preventive care data that people want, like bone mineral densities, colon cancer screening, stuff like that. So I've added this button here at the top, which will insert this form, and what it does is it shows the low risk guidelines for the age and sex appropriate preventive care guidelines, and it has things like your colon cancer screening. It tells you the time frame and the age category that you should be testing people in, and then it's got things like, so you can see here you've got your FOBT and your FIT. It'll tell you what the result was. So in this case, somebody had a positive test, and this was 12 months ago. The provider that can then click that 12 months, and then it'll pull up the results. So you can see they had a FIT, and that was positive, and that was on May 5th, 2019. And then there is also the opportunity on the side there. You can see I'm clicking on the whether the result was due, or the screening test was due, up to date, or whether the patient declined. And you can do that for all of the metrics there. So then, for example, there's other things on here like diabetes screening, your CVD screening, blood pressures, stuff like that. And if the provider clicks on some of those numeric data, like the blood pressure, for example, it'll pull up the graph, so you can actually see that data very quickly and easily, making it faster for people to get the data that they want. Then when you click through, so these are arbitrary selected, but after you've selected all of those data, it's being due, up to date, or complete, or sorry, patient declined. It'll insert this periodic health exam note, which includes some of the risk factors that you need to look through when you're doing your PHE, and then at the bottom it's got a SOAP note. And I don't know if you can tell there, but it will automatically insert whatever you've selected off at the top. So if you said that something was due or patient declined, it automatically puts it there at the bottom as a quick summary for you at the end. And then there are also some extra buttons that are on the bottom there. So I've got like lab rec and fit requisition. You can see those beside where I click that PHE note. Those will insert a lab requisition or insert your fit requisition. I've made, so there's 6 different versions of this. So there's one for male and female, or sorry, 3 for male, 3 for female, and then 15 to 49, 50 to 64, and then 65 and above. There's some other things that are that went into this as well, but that's kind of a quick overview of where I'm at with it right now. I still have to do my data analysis and implementation. We were ready to launch it, but then COVID happened and now we're not doing any preventive care. So currently it is on hold. But that's what I've been working on. And the goal is to try to make it faster for providers so that they can spend more time interacting with their patients and less time trying to search through the chart to get the data that they need.
Super. Thanks, Scott. And thanks for being able to work on the fly there. That's terrific.
Yeah, no problem.
Okay, our next presenter is Dr. Alexander Dodd.
Hi, thanks for having me. Can everyone hear me?
Yes.
Excellent. So I'm presenting my project, which is titled Don't Forget the Phone. We're going to go through this in the what, why, how format. My preceptor and supervisor was Dr. Jason LeClaire. So today we're talking about a prospective review of the Beaupre method of ultrasound-guided foam sclerotherapy for the management of greater saphenous vein insufficiency. So the motivation, you can go to the next slide. Thank you. So the motivation for our project is when we look at the current literature around the treatment of venous insufficiency and look at ultrasound-guided foam sclerotherapy for the treatment of specifically the greater saphenous vein, we see that many of the randomized controlled trials that examined this treatment method limited the number of treatments patients were allowed to receive to 1 or 2 treatments. And then they compared this method to definitive treatment methods such as surgery or endovenous laser therapy, where you actually go in and burn the inside of the vein. And they compared 1 to 1 to 1, so a single treatment of laser therapy to a single treatment of surgery to 1 or 2 treatments of foam sclerotherapy. And they found that foam sclerotherapy was less effective than these other definitive managements. We have kind of a criticism of that interpretation, because when you look at the utilization of foam sclerotherapy, which involves injecting a sclerosing agent into a refluxing vein to irritate that vein and close it off, it often takes more than 1 or 2 treatment sessions in the way that it's clinically employed. So we wanted to design a study that would look at, the clinical efficacy of foam sclerotherapy in kind of a real world setting. Next slide, please. So how did we do this? We prepared a single center prospective chart review at Beaupre Vein and Varices Clinic here in Ottawa. Our participants were patients that were already scheduled to undergo ultrasound-guided foam sclerotherapy for the great saphenous vein insufficiency. And so they underwent the Beaupre method. So essentially the main point here is that the Beaupre method utilizes multiple treatment sessions. So patients can come back, every 2 weeks at a time and get another treatment until the vein is effectively closed. And the outcomes that we were looking at were both clinical and technical efficacy outcomes. So from the technical efficacy side, we were using ultrasound to assess whether or not the vein was open or closed after treatment, and whether there was any flow in that vein, whether it be anterograde flow, which is the direction of blood flow we want to see back towards the heart, or retrograde flow away in terms of a refluxing pattern. Clinically, we looked at patients' chief complaint. So we asked everyone why they were seeking treatment for their venous insufficiency. And at each follow-up, we looked at whether or not they felt that treatment had in fact improved their symptoms. The timeline for this project, we were looking at data immediately at the end of treatment, so after they completed their initial treatment series, and we plan to reevaluate patients at 6 months, 1 year, and 3 years post-treatment. Next slide, please. So these are the preliminary results that we have. This is as of December 2019 when I compiled the data for the research and scholarly project. So this is 20 patients of these 69 patients that we assessed, and these are just the patients that finished treatment first and had data available. So what we see is the average number of treatments that patients required was 2.35, so this is slightly higher than the number of treatments previously allowed in the literature in randomized controlled trials, which was capped at 1 to 2. And when we look at ultrasound technical efficacy, we saw that 95% of patients achieved total obliteration or absence of blood flow within the vein, which is what we defined as technical success. 5% of patients had veins that were still partially open, But when you look at flow, it was in the correct direction. So this is likely clinically meaningful. When we looked at clinical efficacy, 85% of our patients reported that the chief complaint was completely resolved by the end of treatment, and 15% of patients reported that there was at least partial improvement. So at this time, our results are early, they're incomplete, but we're pretty excited about this data. If we can show that this technical and clinical efficacy persists at 6 months, 1 year, or 3 years, then we might need to reevaluate how the current literature evaluates ultrasound-guided foam sclerotherapy and potentially underestimates it. You know, if we see a drop-off in our efficacy over the next 3 years, then our results will just support the existing literature that ultrasound-guided foam sclerotherapy may in fact be less efficacious than other methods. Thank you very much. Next slide. These are my references.
Thank you very much, Alex. And our last presenter is Dr. Valerie Henderson. And Valerie, I don't believe you have slides, but you're just going to tell us about your study. Is that correct?
That's it. So first of all, can you hear me?
Yes.
Excellent. So I'm Valerie. I am the slacker without a PowerPoint. So welcome to my monologue. I'm at the Riverside.
Sorry, Valerie, what I'll do is I'll stop the share and then people can see you.
That sounds good.
Okay, go ahead.
So my supervisor is Dr. Montpetit, and for my project, I performed a structured review to summarize the evidence for whether or not cannabis is an effective treatment for anxiety disorders or not. So cannabis is commonly perceived by the public as a treatment for nearly everything, but including the treatment of anxiety. However, prior research describes a complex and interrelated relationship between cannabis use and anxiety disorders. This project aimed to sift through this diverse body of research and to summarize the clinical efficacy studies within it. This means that I was looking for studies where there were 3 things. Number 1, some form of cannabinoid was administered in a controlled way during the study protocol. Number 2, participants experienced some form of anxiety. And number 3, that a pre and post cannabinoid measurement of anxiety severity was actually performed. After a search of Medline and PsycInfo, I narrowed down 1,716 records to 23 efficacy studies for analysis. To do this, I performed 2 rounds of screening, one at the title level, one at the abstract level, using the systematic review software Distiller SR. So what did I find? In short, fairly weak evidence without a clear answer to my question. Of the 23 studies, 39% of them found that the cannabinoid improved anxiety severity, 17% found the exact opposite result, and the last 39% found mixed or ambiguous results. However, we should be cautious when interpreting these findings, since there's many concerns with the clinical generalizability of many of the included studies. For example, the populations investigated did not reflect the diversity or complexity of patients often encountered in primary care. The studies generally focused on small groups of healthy, male, non-elderly volunteers who performed an anxiety-provoking task while under the acute influence of a cannabinoid. Only 13% of the studies included patients with a clinical diagnosis of anxiety at all. Additionally, many different doses, types, and formulations of cannabinoids were used, making it really hard to cross-compare and synthesize study results. They used purified extracts of THC, CBD, nabilone, as well as various strains of herbal cannabis, which they failed to specify. Nearly all of the studies used an oral administration route, which doesn't necessarily represent how most people dose and consume the drug in real life. Interestingly, purified CBD had the most positive studies associated with its use. However, all but one of these studies was done by the same research group, so replication by others would be beneficial. Also, the techniques and questionnaires that were used to measure anxiety in the studies weren't the same as the ones that we use in the clinic, which really limited generalizability. Finally, most studies only measured the acute effects of the cannabinoid, as in within minutes of consumption, when we know that most patients with anxiety will actually suffer chronically. In conclusion, despite the popularity of cannabis and its use for anxiety, there is a lack of strong evidence supporting its efficacy at this time. More research is definitely needed before cannabis or any purified cannabinoid can be prescribed confidently as a treatment for anxiety. In the meantime, primary care providers should practice prudence and shared decision-making when discussing cannabis use with their patients suffering from anxiety. And that's it. Thank you.